Hi, I'm going to go over the pediatric cardiology submissions that you guys did and hopefully point out some things that you need to know or things that are not included on your sheets, and I will send out the sheets. The first one is patent foramen ovale versus a ASD. So the big difference is that the foramen ovale is a normal structure. Everyone had one, and it was the reason why you were alive in the uterus. Remember, in the uterus, the left side of the heart has very little pressure. Normally, the left side of the heart, for us, is our big ventricle, and it does all the hard work, basically, and the right side just pumps to the lungs. Well, in the uterus, the lungs get basically bypassed, and you're using the placenta. And the right side of the heart is the one that's getting worked the hardest. So you get right side of the heart, and then you get pumping, and you have blood that goes from the right side to the left side via the patent foramen ovale, or because it's patent then, that just means it's open, right? When the left side of the heart have more pressure, there's a flap there, and that just gets closed. And in most people, it becomes kind of like grows together. That's the word I'm looking for. And so you can't push it open. But there's two people that actually did this assignment. Well, as one of them said, on autopsy, about 25% of people that can actually take their finger and open it up. So a patent foramen ovale is not usually a big deal unless there's something else going on. We'll see these quite frequently. They can be present with other sorts of heart disease, and then that makes them a difference. Where an atrial septal defect is actually a hole in the heart and needs to be fixed. The next one here is the VSD. VSD is the most common true congenital heart disease found. So the ventricle has a muscular part and a membranous part. The muscular part is towards the bottom of the ventricle, and the membranous part is at the top. A muscular VSD will almost always close up on its own as the muscles just grow and tighten up with age of the child. The membranous ones almost never do, so those have to be repaired. If you don't get these repaired, it puts these children at a much greater risk for endocarditis later on down the line. So if you hear a murmur, and this is usually a pretty harsh sounding murmur, you need to get it checked out until you get very comfortable with murmurs. The most common thing we hear is like a Stills murmur, a primary pulmonary stenosis murmur, an innocent murmur, that sort of thing. It's just a murmur. It's a systolic murmur. That's usually a 1/6. About 10% of the population has them. We hear them worse if you are running a fever, pregnant, somehow dehydrated. You're going to hear those kind of murmurs worse. Those are non-pathologic. They're just there. So we don't worry about those. But this is the most common, truly congenital heart disease. Iron deficiency anemia. Remember those microcytic cells that you see on a smear, and then you can kind of tell that that's iron deficiency anemia. So iron deficiency anemia in a very young child is usually diet related. However, it can be from blood loss. For an older adult, if they have iron deficiency anemia, then the first thing you got to think about is some sort of GI bleed. Even like a teaspoon a day can, over a course of many months, can cause a significant anemia to develop, and it develops slowly, so they kind of compensate for it. Now, in a menstruating woman, of course, that's the usual cause, but in children, mostly it's diet related. So often you'll find that the child has a high milk diet. They're just drinking a lot of cow's milk, and they're not eating a lot of other meats, fruits, and vegetables, and that sort of thing. So typically you check for hemoglobin levels somewhere around 9 months and 2 years. All right, but there's other conditions that can cause it as well, or mimic a iron deficiency anemia. But anyhow, just be on the lookout for that. And if you see that, and especially if you are treating with iron and it's not getting better, then you need to look further into some more CBC studies, that sort of thing. And you have to worry about things like thalassemia, which you can actually get an iron overload. So if you're treating with iron that they're not getting better, don't just keep treating with iron. Check it out. Make sure that what you're treating is what you think you're treating before you get your patient in trouble. Next one was tetralogy of flow. I think most of you guys should be familiar with that. That's the little squatters turn blue and they squat. Usually we pick it up way before then, but just kind of be aware of it. That's a pretty common one. You might see that on some kind of Bacterial syndrome is something, it's not really a cardiac disease, it's more of a syndrome, but or they call association here. And alone, it may or may not be something, but you need to just be thinking if you got somebody with renal disease and they got like a vertebrae, you get an x-ray, you see a little hemivertebrae, and they have a limb abnormality, just kind of look for that. And if you don't know they have a cardiac disease, you might want to look at that then too. This one is hypoplastic left heart. Now, usually, when you see a hypoplastic left heart, they are going to do very badly almost immediately after birth and end up with on ECMO and some kind of corrective or palliative type surgery, and then end up perhaps with a heart transplant. But there are a few that have, it's kind of minor and they kind of hang out. I've got one in the office right now. And he's 4 or 5 years old at this point. So this is something you might see. So you just need to be aware of it. This is where the left side of the heart, which I told you earlier, should be the big, strong, meaty part, is just doesn't work very well. And they just don't pump blood very well. And there's a nice drawing, there was a nice illustration in this particular handout. This one's transposition of the great vessels. Once again, this is very often something they're not going to do well real early on. And they actually do things like you have two systems going. So you have the right side and the left side, and the two don't meet. And except through the ductus arteriosus. So when the ductus arteriosus closes off at about 48 hours of age, these kids will do badly in a very big hurry. So what they'll do with this often is put kids on prostaglandin E, and the point of prostaglandin E is to keep that ductus arteriosus from closing. They'll also do a procedure where they actually go through the foraminal valley and put a balloon in there and just kind of pull it from one side and kind of rip a big hole in the atrium and cause an ASD so that they can have mixing there. This is usually not a good thing. Now, she has some a statement in there that there's a percentage of people that have this and do well their whole life, but that's because everything is backwards. So it's not just the great vessels are backwards. Everything in the chest is backwards, and I've seen that like 2 or 3 times. You'll get this X-ray and you're like, it's flipped, it's backwards, and you turn it over, and then finally someone goes, no, it's not flipped, that's right. So anyhow, it's interesting. RSV is super common, and I really wanted to talk about this at some point during your class. RSV is a cold. It's a cold. It's kind of like, we're dealing with COVID right now, which is basically a cold. But for some people, it's a cold that has dire consequences. RSV is kind of like that too. So for very young children, people with pulmonary young children with pulmonary compromise for sure, this can be a very devastating diagnosis. But for most of us, it's a cold, and so you can do a nasal swab for RSV. I don't do it over the age of 2 for sure, because at that point it's like, okay, you know you've got it. Who cares? You're not going to do anything different. For young children, especially under 6 months of age, this can be life-threatening and can kill them. So if you have the younger the child, the more concerned you're going to get. But the primary symptom for this is a cough. So if you get a 2-month-old that's got a cough, you better think about RSV. Typically, we'll do an RSV test. If you give them albuterol, they'll be wheezing and they'll sound horrible. Albuterol, steroids don't really help. It's just really supportive care and time, although you'll see both of them given for RSV. They've not been shown to help. It's more oxygen, just kind of keep them alive till their body gets over it. Kind of sounds like COVID, doesn't it? So that's what's going on there. There is an immune globulin that you can give monthly to very young children to give them some passive immunity. It only hangs around for a month, so that's why you have to do it monthly. We do it during RSV season, and it's very expensive, so insurance will only approve it for the most high-risk children. But anyways, just be aware of that. Kids that have RSV do tend to have more issues with reactive airway disease, that looks like asthma for the first couple of years of life, and then after that, it usually, if it's just related to the RSV, it'll kind of clear up. But just be aware that if the parent has a child with RSV, next cold they have, they'll be on wheezing, and then you can give albuterol, and it will help. This one is asthma, and there's going to be more details on asthma coming up, so read over this. Asthma is super, super, super common, unfortunately. So just kind of be aware that that is something that we will be talking about later. Epstein's, I have seen this like a couple of times in my career. It is not good, as you can imagine. So she's got a nice little write-up on it here, so just kind of read over this. This probably won't show up on boards. It's kind of not that common, but kind of nice to know about it. Coarctation of the aorta. Another thing that's actually fairly common, and it really, the coarctation can be terrible, terrible, terrible. The kid can get to that 48-hour mark when the ductus closes down and really die. Or it can be fairly mild and you only catch it because they have hypertension when they're 3 or 4 years of age. So this is just a kink in the aorta somewhere. So it depends where the kink is, if it's pre or post ductal, and how big it is and how big of a segment of the aorta is involved. But just kind of be aware of this. It's super common. So if you got a kid with hypertension, the biggest reason, and we'll talk about this in a few minutes, for hypertension in children is renal. But this can be kind of the cause of why they have some renal disease, because they're not getting correct blood flow. Some of these really bad things, for instance, hypoplastic left heart, don't have murmurs either, which is really interesting. So some of the worst cardiac diseases you can get don't have a murmur, and some of the ones like a BSD, which is, for most kids, pretty easily corrected and not that, well, any kind of heart disease is a big deal, but not that big of a deal, have a terrible murmur. So just be aware of that. Look under AV canal, but the big thing you need to remember, AV canal Down syndrome. Just remember that. You'll probably see that on boards. So if you got a kid with Down syndrome, they need an echocardiogram to check for AV canal. Aortic stenosis, nice little pamphlet that she's got here. You guys can take a look at it. Just the aortic valve is stenosed. There is a murmur. Depending on how bad it's stenosed, it might need to be replaced. Just be aware of that. Diaphragmatic hernia. Fortunately, they're doing a lot of fetal surgery now, so we don't see as many of these as we used to. but that's just basically where the diaphragm doesn't develop right. It's usually on the left side, and the intestines are up in the chest where the lungs are supposed to be, so the lungs don't develop, so they're hypoplastic lungs. And these guys can be terrible. And the big thing, if you ever go to deliveries from this one, is you see that their abdomen is just sunk, and they do terrible. So if you ever go to a delivery and you see a kid with they look like they've got nothing in their belly, because everything in their belly is in their chest, and they're doing bad quickly breathing, then think diaphragmatic hernia. And the big thing you want to do with that, of course, you guys won't have to do this, but you need to intubate them so you don't get a lot of air down in the lungs that can cause major issues later on. These kids can be from very mild to terrible. Sometimes we'll even find you'll find a small hernia just on x-ray, later on. So it hasn't got too much of a problem. So just be aware of that. She did a good job on polycystic kidney disease. This is often hereditary, and it can be awful. It can cause something called Potter syndrome, where you have this big belly because the kidneys have been so overextended and have so many cysts. They don't work very well. The bladder is real distended. The ureters are huge. So you get this big belly. The musculature just did not occur in utero, and then you get these little hypoplastic lungs, because remember, most of babies are breathing in and out. It's really not amniotic fluid, it's pulmonary fluid, but it's kind of like that. The pee makes it. So if they don't have enough amniotic fluid, because the kidneys aren't working, they're not peeing, they're not making amniotic fluid, they can't breathe, so they end up with these terrible little lungs, and they can be very, very ill. And then once again, this can go the gamut. You can have one kidney that's got polycystic, and the other is okay. Usually they'll remove the bad kidney. But this is kind of devastating for families, because it can, and very often is, hereditary. Supraventricular tachycardia, you could see this at any age. Depending on the age, the number that you're looking at. If you're looking at an adult 120, you could be thinking SVT. In children, small children, infants, we're at 200, 220, because remember, their heart rate is normally around 160. So if you had a very young infant, just kind of be aware of that. Usually over the course of hours, they'll start compensating and turn blue. But the big thing you want to rule out here is that they don't have WBW, which we'll talk about later on too. This is treated with DIG usually, or some other sort of drug of that type, or it can be treated with ablation to correct them, to get them out of SVT. You can give a medicine called adenosine, which actually just stops the heart for 6 seconds. And usually you need to do that with losing the name of this thing, like the paddles for coding, right there at the ready, because the heart's supposed to stop for 6 seconds and restart. It might not, though. And I actually had a case where a nurse practitioner ordered adenosine to be pushed for someone in SVT by the RN, did not have like the code team kind of sitting there, or any kind of paddles or that sort of thing. The patient did not do well, and the nurse practitioner was in a world of trouble for that. So don't be that person. The other thing you can do with this is synchronize cardioconversion too, with the paddles, so synchronized shock. Sickle cell disease. This is a disease that we do test for in the neonatal period when they do that metabolic screening, they test for a bunch of different things. Hypothyroidism is one of them. I don't even remember what the numbers now. It's something like 30, 40 diseases. And every state's a little different as far as what they test for. But one of the things that we definitely test for is sickle cell. If you are a carrier of sickle cell, you can still have a sickle cell event. Usually it takes a lot more situation has to be a lot more dire type thing. We think about these people getting dehydrated, like being in sports, getting dehydrated, and then going into sickle cell event. And this is extremely painful, just to be aware of that as well. So these folks often need narcotics. Hypertension in children, always think renal disease in kids. The older kids, especially the overweight kids, and you can start seeing the more adult causes of hypertension, just, being overweight and that sort of thing, secondary hypertension, but or primary hypertension. But in children, it's usually secondary to kidney disease, and then can be caused by some of the other cardiac things that we talked about earlier, as coarctation being one of them. I forgot to mention there too, she also has a nice article on treating hypertension, so you might want to take a look at that as well. Familiar hypercholesterolemia. This is an awful, awful diagnosis. And this is good. You'll see these kids, they have like these little cholesterol growths on their skin. And you'll see them in adults too. Their cholesterol level, we have one little guy in our office, and he's like 14 right now, I think. But he ended up with a liver transplant, but his cholesterol was running, 400 or 500 on, up to 6 statin medications at one point. Their life expectancy is understandably short. So this is a horrible diagnosis for families. This kid was diagnosed at the age of 2 because he just had those little cholesterol growths coming up. And then the last one is WPW. And I always just want to, I always want to say W. But this one, Wolff Parkinson White, this is another hereditary type thing. You really have to watch these kids with sports. Okay, they really need to be treated, and they need to be under cardiologist's care. We had a whole family that were homeless. They were living in a tent up in the mountains in Walhalla, and they'd been there for a while. And the kids, they kind of came down from the mountains basically and saw us. And none of the kids had seen a cardiologist, had been on any medication for years. This can definitely cause sudden cardiac death. So just be aware of this, and if you do have SVT, be thinking better. SVT, yeah, it's usually, it's not much fun, but usually it can be controlled fairly easy. But you want to make sure they don't have WPW. Although we have had, I can saying that, but we have had kids that there were almost continuous SVT, and that ended up killing them alone. Just could not treat it with enough medications to block it. There was no one point that they could ablate. So it that's unusual though. Anyways, I hope this helped a little bit. Talk to you later.